Actually, I like this case from educational point of view. We have patient here, female, 27 years old, a young female with advanced sarcoidosis, diagnosed by biopsy after first HRCT done on 2017. Then she underwent further follow-up HRCT in 2018, then 2022, and the last was 2023. Here I show you the 23 because it's a stationary course. If you are interested to have a look on the other scans, I will put a link for the other case, other scans, which I shared in a post on Twitter. Let us discuss the case with our systemic approach that I was always emphasizing and insisting to mention it. In every case, we have interstitial lung disease. First, we have to decide we have fibrosing interstitial lung disease or non-fibrosing interstitial lung disease. Here we have fibrosing interstitial lung disease. There is fibrosis, irregular reticulation, traction bronchiectasis, irregular reticulation, and traction bronchiectasis. Still, honeycombing didn't appear. Here we have fibrosis is increasing in the bases, and honeycombing started to appear in the posterior angle. So apparently it looks typical UIP, but here we have emphysema in upper lobes. So we have two possibilities here: combined pulmonary fibrosis and emphysema versus advanced sarcoidosis. First, I think most of us knows the combined pulmonary fibrosis and emphysema, which is smoking-related emphysema in upper lobes and pulmonary fibrosis in lower lobe, either UIP pattern or NSIP pattern. But in the upper lobes, it should show in combined pulmonary fibrosis and emphysema, centrilobular emphysema and paraseptal emphysema, which is the emphysema related to smoking. But the emphysema that we are seeing here is along the fissures and along the bronchovascular bundle and along the fissure. This is the paracicatricial emphysema. It's one of the features of pulmonary fibrosis that almost always confined to sarcoidosis. It's rare to be manifested by sarcoidosis, but it can happen with sarcoidosis. And in literature, personally, I didn't read that paracicatricial emphysema can happen in a systemic disease or in a fibrosing lung disease. It can be seen in like complication of TB, can be seen in COVID-19 pneumonia, sequelae of paracicatricial emphysema, but in IPF or other progressive pulmonary fibrosis, it's not the case. So again, if we have the pattern here, which apparently looks typical UIP, we will think this case is IPF or non-IPF. Here, because of the paracicatricial emphysema, so we will think of alternative diagnosis. And what entity can present with paracicatricial emphysema and upper lobes? It is the sarcoidosis without differential diagnosis. And the issue here and the problem that you can misdiagnose or misinterpret the emphysema as combined pulmonary fibrosis and emphysema syndrome, which is not the case, because again, the emphysema in CPFE, combined pulmonary fibrosis and emphysema, is smoking related, centrilobular emphysema and paraseptal emphysema. Here we have paracicatricial emphysema. So the trick in this case that is the awareness of the paracicatricial emphysema. At that time, you will diagnose correctly the sarcoidosis. If no awareness of paracicatricial emphysema, I think most of the interpreters or radiologists will go for combined pulmonary fibrosis and emphysema. And here I will show you the coronal as well, which shows nicely that the emphysema seen along the major fissures and bronchovascular bundle. You can also go to the link and see the other HRCTs in Twitter. And here is the sagittal also. See the emphysema along the paracicatricial emphysema because of fibrosis, not because of smoking related disease. And thanks for your attention.